This is Duke University.
We've decided that we're going to take each one of the physicians and we'd like each person to be assigned to an individual physician. So for those of you who I don't know, I'm Kyle Cavanaugh, I'm Vice President for Administration, and we've been spending quite a bit of time on this topic over the last couple of months, quite frankly. So what we're here to do this afternoon is to talk with you candidly about the Ebola situation and specifically what we've been doing across Duke, which includes the health system and the university, to provide as safe an environment as possible. We've been looking at this from every angle that you can imagine. We've been paying attention to it on the global page. And one of the things that I keep getting reminded of, and the best data that we've got right now is from 2011. And so in 2011, there were 60,000 people in the United States that had died of the flu or influenza. Right now in the U.S., in terms of the Ebola situation, there's been one. So if there's nothing else you hear this afternoon, I want you to take this away. If you've not gotten your flu shot yet, make sure you get out and get your flu shot as soon as possible. We've been looking at this across the entire gamut of the different facets of Duke. So of course, we are a large healthcare enterprise, and our partners in the healthcare side of our operation have been long about the business of ensuring they have protocols and appropriate procedures in place to identify and to deal with if they did face the unlikely scenario of having a patient present with those conditions. So we'll talk a little bit about those parts. Nearly 2 months ago now, there were restrictions that were placed in through what we refer to as the International Travel Oversight Committee, or ITOC, at the undergraduate level. So there were restrictions at the undergraduate level in terms of travel to impacted countries in West Africa. This week, we've put in some additional parameters in terms of graduate students and faculty and staff, and have an exception process that is underway to take a look at that. The intent of that is to ensure that we're providing as much support for people that may legitimately be traveling to those locations, as well as managing as best we can anyone who may be returning from those locations. So there are a lot of pieces into that. This afternoon, we've assembled 3 physicians to have a conversation with that will look at this from a variety of perspectives. Dr. Cameron Wolfe is an infectious disease physician. We are incredibly fortunate to have him at Duke. He's been playing a significant role not only at Duke, but also in constant contact with national, if not global kind of folks that are in this space. Carol Epling is our physician over employee occupational health and wellness, and we'll talk from the employment perspective and things that we've done there and preparation activity that we have underway in that arena. And Dr. John Vaughn is our director of student health, and we'll talk about specific issues in the student area. So I know we're small in number, but I know we've got a lot of energy behind you. If you could join me in giving a quick round of applause for Dr. Wolfe, and we'll get ourselves started. Cameron?
It's nice to follow Kyle because he may be the only other person who sticks the microphone this high, I think. Hey, so I wanted to sort of begin actually by sort of going through something that we've been trying to equally go through on the healthcare system side, which is a clear dissection of what we're dealing with here that's fact and what we're dealing with that has been a little bit of hysteria, quite frankly. And as I'm sure you can see here, actually many more people in our country saw the Bloomberg report than they ever have seen the facts about Ebola that the CDC published a couple of weeks ago. So if nothing else, I just want to really try and reiterate some fact from fiction. So let's start by putting this in a bit of a historical context and then begin to understand why this outbreak has been so different. I'm not sure how well it projects, but essentially what you can see here with small green dots centralized really around central equatorial Africa historical measures of severity of Ebola outbreaks that have occurred really as far back as 1976 when we first recognized it. And for the most part, we've actually been able to learn a hell of a lot about Ebola because of each of these little outbreaks, how it's spread, how it's been contained. And as you see, all of those outbreaks are actually sizably smaller than the ones that are currently going on in the parts of West Africa that we'll be talking about. Geographically, these were fortunate in some sense historically in that they were occurring in parts of the world that were both at the time and in fact geographically so isolated as to not really allow infected individuals to move out of significant forested areas within Congo, Brazzaville and parts of western Uganda. What we've noticed this time is, of course, parts of West Africa and in fact particularly in 2014 have much more defined and liberal use of transport, and we've actually been able to export this illness, as you well know. So let's get in a little bit more specifically about West Africa, and the part where we're talking about in particular is the small little area here on the border between, really on a tri-national border between Sierra Leone, Liberia and Guinea. And we can now, in retrospect, actually go back as far as December of late last year to recognize just the first couple of cases that in hindsight were clearly early Ebola that were not picked up here. And there's a number of reasons why this was so poorly understood earlier and so frankly missed. First, it had never been an area that had experienced Ebola before. So when people were coming forward with symptoms of hemorrhagic fever, it was not something that was on the top of clinicians' mind, and it was not something that was understood at all by local populations. Additionally, what you can see there is that, as I said, this is really on a border area of this part of the world. And in fact, the bottom picture is the border at some point between Sierra Leone and Guinea. So you can imagine just how porous this border is, how frequently it's cross-traveled, and therefore how difficult an infectious disease is to potentially control. The third part of it that makes a big difference here is that this is an area that's been terribly afflicted over the last 20 years with sort of geopolitical instability and ultimately poverty. And so each of these three countries line the bottom dozen of our World Health Development Index. And you know, two have come out of civil wars, and the one that didn't was Guinea tried to assassinate its president in 2009. So I think you begin to get a bit of a picture of the health framework that was trying to respond here was poor from the outset. And I think I've included a quote there from Margaret Chan, the current Director General of the WHO, which I think sort of sums everything else into one word, that this is an outbreak born of poverty. So to get a little more granular, this is a weekly update that the WHO try and compile that sort of looks at new cases in this part of the world. And to be clear, any dot that is a red dot represents a new burden of infection within the last 3 weeks. And anything that is a grey circle represents the cumulative total in that region for all infections dating back as far as we could track them throughout the outbreak. And so I think one of the things that you notice and why we're putting so much effort here into preparing for Ebola is that the majority of these cases are all red. So these are new developing cases that are exponentially increasing in terms of both number and in terms of breadth on those countries. You do see a few interesting geographical nuances though, which is that at least so far, Côte d'Ivoire has been able to stay out of this and has remained Ebola-free. With the exception of one individual who travelled, Senegal has remained Ebola-free, as has Guinea-Bissau and Mali. Although again, these are pretty porous borders, and I'd be unduly risky, I think, for me to say that those countries will continue to remain negative, although they're trying hard. So if you tease apart two of those countries specifically, Sierra Leone and Guinea are actually not the most busy country at the moment. It's actually Liberia, but I think if it doesn't take an epidemiologist to look at these graphs and realizing that they're unfortunately not heading the right way when it comes to numbers of new infections. And then if you look at the way the CDC would sort of model this, and one of my chiefs jokingly says that he's most scared of this because the CDC almost never get their modeling predictions wrong, is that we sort of, we sit here currently in middle of October. And so these are estimates of predicted numbers of infections in West Africa if we do nothing. The solid line represents the modeling for numbers of cases that we actually know about and that have been proven. The dotted line represents the number of cases that we think are also occurring but just don't ever make it to healthcare attention or maybe turn up and get turned away from a full hospital or simply don't get tested. So if you take a pessimistic view of this and say, well, if we don't do anything, we're looking somewhere between 1.4 and 500,000 people infected by mid-January. So let's talk a little bit about clinical disease, because I think equally there's a lot of misnomer in the media about what Ebola truly is, and I don't want to make this a medical talk, but I think it's useful. So this is an illness that is not instantaneously impactful on people for whom have been exposed. And in fact, there's a variable time window between when you can be exposed and to when you actually begin to show symptoms. It's typically around 8 to 10 days, but it can extend as long as 3 weeks. And initially, one of the real challenges, I think, in West Africa and also actually here has been that the symptoms are not particularly specific. There's nothing about someone's presentation in those first few days that specifically says, you know, this is clearly Ebola. This, to me, would be the akin of someone who has a bad flu or a bad case of food poisoning, and it's very hard to differentiate between them. However, as things become a little more progressive, this is a leaking disease, both internally with vascular leak, and people can't contain their own fluid within their own blood vessels, but it's also an effluent-producing disease with sort of cholera volume diarrhea. And so actually the reason people in West Africa get into so much trouble with mortality up and around 80 or 90% historically is that we can't keep up with their fluid volume loss, and they die either of dehydration complications or electrolyte problems. Currently, we're looking at about a 70% mortality in West Africa, although that's possibly an underestimate because we don't find every case. This is a multi-organ disease ultimately, and the stereotypical picture of this being a hemorrhagic disease actually is in the minority. It's probably about a third of people run into real problems with bleeding. Clearly, the more organs you have that are involved and the less that we as clinicians can keep up with someone's fluid loss, the more someone's chances of dying increase. It's a virus that's physically found in all of our body fluids, essentially. So the challenge has always been, how do you maintain an adequate boundary between an infected individual and their family members or clinicians when blood, urine, diarrhea, feces, semen, all of which can be active virus carrying body fluids. So a couple of key misnomers I think to correct is there's been a lot of chatter in the last week in particular about could there be any science that points towards this being airborne? And there's 1 or 2 papers that get quoted that have said they can't rule out airborne spread of this illness. And when I say airborne, I mean like the flu. But we have had, if you think back to that first slide, multiple small outbreaks of Ebola that have absolutely proven that not to be the case. So this is a fluid-borne illness, and so really the only way of coming in contact with Ebola is through intimate contact with someone else's body fluids. So actually the people who become the highest risk here are sometimes actually our healthcare workers or people who are nursing someone through the last phases of their illness, or in fact look after a recently deceased individual. The more sick you become, the more virus you have in your body. The more sick you become, the more likely you are to be vomiting and having diarrhea, which is why it's such a difficult issue as someone nears the most severe part of their illness. Beyond 3 weeks, actually the risk, if you've not become sick already, the risk of developing illness at that stage is really vanishingly small. And this was a study from a couple of years ago that really said beyond that sort of 3-week mark, essentially the risk is zero, recognizing that some of these cases were incorrectly picked up, the theory is, because it's not immediately clear that people didn't have a second exposure. So really, if you've made it through 3 weeks, having come out of a country with Ebola, the chances are you're not going to get sick. So we've used that as our sort of delineation point. Part of the big issue that happened obviously in Dallas is that, it was not identified on the first time the individual turned up to the hospital that he was at risk of Ebola. So a lot of the issue that we've been trying to battle here in the healthcare system has really been to say, how can we have early detection of anyone who's at risk, put them in a situation where they are geographically and spatially isolated from the rest of family members and healthcare providers, and how can we quickly sort of detect that that's the case? I'm sure it's not news to any of you that Duke has an incredibly broad footprint as a healthcare system, and sort of more than 150 primary care clinics, urgent care clinics, 3 major hospitals, a number of big ICUs, and many other hospitals actually that feed into our system. So to physically be able to put in place detection mechanisms that would pick up someone in our community who may be at risk of Ebola has actually been a real challenge and something we've been working on for a good number of months. It involves actually good communication with our EMS colleagues. It involves great communication with our state and county health department. There's active communication with UNC. And then there's a lot of obviously sort of internal communication that tries to get to the point of how can we pick up someone early on to get them into an isolated and secured place. All of our clinics now across the whole healthcare system have actually already been delivered a series of what's called PPE or personal protective equipment. And this is the kind of stuff that allows individual clinicians to be in the room looking after patients and not be at risk themselves. Additionally, we have a lot of transfers that come in, so all of our transfer centres have to be mindful of how they can potentially pick up these individuals who might be at risk. We've tried systematically across the whole healthcare system in the last couple of years to make it as easy as possible for individuals to book into our clinics. This is not the kind of situation where I want someone who's just come out of Liberia to freshly be able to turn up to my ED. So putting in place lots of checking mechanisms has been a part of our preparation here. And so all of this essentially channels down to how do you actually manage a patient who's potentially infectious? How do you evaluate them? And if in the unlikely situation that they're positive, how do you look after them? So Duke is actually in a somewhat serendipitously for good position in terms of this, both in terms of our local resources, in terms of expertise, but I think also in terms of our local in-hospital management capacity. As you may know, we've obviously built a large number of wards recently specifically to expand our hospital capacity, and it has allowed us to create a very isolated unit that we think would work very well as a place to care for someone who would present to us with Ebola. It's been one of the great difficulties, for example, in a place like Dallas, is that unfortunately they did not have a specific isolation area and had to care for the gentleman there in a regular part of the ward. So all of this boils down to just 3 questions. And this is what we believe is actually an incredibly effective way of detecting any risk for Ebola. Have you traveled outside the United States in the last 3 weeks? Is the first one. And 99% of all of our visiting patients answer that question with a no, in which case they can move on. They're not at risk of Ebola. There's a limited number of people who might say yes. We do actually have a pretty decent-sized West African diaspora in Durham County, not to mention North Carolina. And so if you answer yes to that question, then the specifics are, have you been in the last 3 weeks to the countries of Sierra Leone, Liberia, or Guinea? And then are you symptomatic? And depending on someone's answers to that, they very quickly move down a triage line that essentially reaches myself or one of our other infectious disease colleagues to really be very careful and understand what that person's risk is. The sooner this happens in the healthcare system, the better. So all of our frontline staff are asking those 3 questions now. And I would challenge you, if you turn up to one of our clinics and don't get asked these questions, that frontline travel one, then let us know, because we want to circle back to that clinic and reiterate that. As I said, for the majority of people, it's a 30-second question. Have you traveled outside the United States, sir or madam, in the last 3 weeks? And they'll say no, and the conversation ends at that point. If on the unlikely chance that we actually have someone who screens as a possible candidate, then things actually move up to an escalated situation where we activate an internal Ebola response plan, would move the patient to the secured location that I was describing, and actually take over their care in a very selective fashion from that point onwards. For those of you that do turn up and use our healthcare facilities, you'll probably notice these banners now appearing. It's equally a way to help our patients identify that we would like them to self-identify if they've actually come out of West Africa in the last couple of weeks. Similarly, internally facing at all our frontline clinics have the same messaging, making sure that as quickly as possible when someone comes forward that they're seen as either being no risk or someone who we have to evaluate further. So let's think about why I think Duke is in a little bit of a fortuitous position compared to other places. So for a start, a team that actually work here at the hospital in terms of an infection control committee has been, I would argue, probably one of the country's leading infection control programs for a long time. They're already holders of a number of big CDC grants specifically looking at infection control programs, and this, I think, really dovetails into what they do on a daily basis particularly well. Other centres around the country, unfortunately, have not had that ability and have, unfortunately, run into some problems, as we all know. We actually have a safety office here that similarly really only occurs in hospitals that get to the size of Duke. So not every university and not every hospital have specific safety offices set up to liaise, for example, between our university and our healthcare system in terms of ways of building safety into everything that we do as a daily routine, not just that last little layer of protective equipment that you use. Many of you may not actually be aware, but we also have a very high-end research unit that actually operates just down the way here on the campus, and their daily research sort of mandate, if you will, is to specifically look at research into high-impact infectious disease. And so they would, for example, regularly deal with things like plague, multi-drug resistant TB, avian influenza, tularemia, things that require incredibly specific and incredibly carefully set up laboratory facilities to research. They've then been an amazing tool for us to come back and say, hey, we need to equally set up all of your safety protocols up on our isolation unit to make sure that we're doing exactly what you do and to do it as dogmatically as you do it. And that's been an extraordinary resource. Part of actually, the other part that's been challenging as a healthcare system is that this has been a moving target. This was not in the media a month ago. This has become particularly in the media in the last couple of weeks when a number of healthcare workers have got sick. So there's been a little bit of a moving target in terms of what recommendations have come down the pipeline for us to respond as a healthcare system. And actually the reassuring thing from my point of view is almost every updated state and CDC recommendation that's come out just this week really matches what we've already been doing for a month, which I've actually found pretty reassuring. So let's talk about when things can go wrong very briefly from a healthcare point of view. And it would be wrong of me not to talk about a West African context here. So this is, as I said at the beginning, this is an illness where you become more infectious to the people around you, the more sick you become. And so by definition and by extension, then healthcare workers are at particularly high risk of acquiring Ebola in that context. And there's been a number of colleagues in West Africa who've got sick. And so to put that in real numbers, Liberia has a population pretty comparable to North Carolina, actually, and previous to Ebola had 200 physicians. We probably have 2,000 physicians if I counted them up across the way here. And that number of 200 is now 50 for the entire country. So if you want to understand the impact of what this is having on the ground, then that's just a very real statistic. Here in the West, at least, it's been a very different issue. We've had, as you well know, 2 documented cases of healthcare worker-acquired Ebola. There's been 1 in Spain, and to my knowledge, that remains the only individuals outside of West Africa infected. When it works well, actually our care can be incredible, and these are the 2 individuals who first came through Emory, repatriated from West Africa with illness. And at least as of this morning, Emory have now allowed 3 people to recover and go home. Nebraska have allowed another couple as well, and we have 1 death. Both nursing staff are actually doing really well from my latest update as of this morning, although still remain in hospital. So when it works well in the US, it works fantastically well. In the interest of time, this is the kind of caliber of the stuff that our staff have to wear. Particularly the picture here on the left is an example of that biosafety lab, what they get trained to wear every single day. And they are incredibly particular about putting themselves into it, taking it off, putting it in, taking it off, and have been training our staff for the last month to do exactly the same thing if the case ever arose. It's hard to get into, to be honest. It's hard to operate in, it's hard to take it off. Many of the fears that came out of Dallas was that perhaps the reason that some of the nursing staff may have become sick was their inability to correctly take this off without smearing themselves. So we've been fighting a sort of misperception, if you will, that more personal protective equipment is by definition more protection, and that's clearly not the case if you're not well trained in it. The seemingly less personal protective equipment that you see on the right is actually very appropriate for the management of anyone in a primary care setting and an urgent care setting where where their purpose in our model is to identify the individual early and transfer them to a secured location. Similarly, this becomes a far more safe model to use in someone who's far more sick and actually may have more diarrhea or more vomiting and more ability to spread illness. Whereas in fact, this kind of protective equipment is actually really helpful at the very early stages when in fact the most likely thing that you have when you've traveled from West Africa and have a fever is influenza, typhoid, malaria, and in fact Ebola is way down the bottom of that list. So just to briefly sum up, I'm going to go over a couple of interventions that you may have heard about in the media and to talk about them a little bit. So things that are proven is if you think back to what the illness is, this is an illness with an incredible amount of fluid leak, be it diarrhea, vomiting, or internal fluid leak. So actually the biggest single thing that has helped the individuals who've survived at Emory in Nebraska and in different hospitals in Europe has been aggressive fluid replacement and electrolyte supplements. And this is something that clearly a hospital like ours does every day. It gets a little more challenging when you have to start doing that in protective suits, but on a fundamental level, this is not a hard illness to care for, it's a hard illness to make sure you do it right. There's been a lot of media talk about treatments, and so let's put that on the table just briefly, because actually we're in a kind of a unique position here in that at least one of the companies making the treatments happen to be 10 miles down the road. All of these treatments that you hear about in the media have been studied in the numbers of patients that would be less than 10. And so we have to understand that in the context of how effective they may or may not be, we frankly just don't know. So when the media come and talk to us about the success of ZMapp, the combined antibody product that was used on the 2 people at Emory, they may well have survived because they were getting great standard of care in Emory Hospital and self-selected themselves to be well enough to make it out of West Africa on a plane, and ZMapp may have had nothing to do with it. But I think one of the things that we will hear further discussions of in the media is the use of these products, and at this stage they remain completely experimental, both here and if used in a West African context. Actually, probably the thing that to me makes the most microbiologic sense is that you collect the pooled antibody responses of survivors and give them to people who are still sick. It's a big issue for your healthcare workers to put them under surveillance, but this is something that obviously is a part of our plan. So, as you well know, some of the individuals in Dallas went, for example, got on a plane and went to Ohio. And so part of understanding your working responsibility when you're in a unit caring for someone who may have Ebola is that each and every one of the people on that unit, and it's going to be a very small team intentionally, have to go under the same surveillance program themselves to make sure if they get sick, straight away they can come to Carol or myself and we can understand what's happening with them. It's a big commitment from our staff. It's a commitment to want to volunteer to be on that ward in the first place. It's a particularly big commitment to then say that I'm going to take the additional time after I've cared for someone to make sure I don't get sick myself. And obviously that involves travel restrictions. This is a big issue finally for the lab and for our radiology support staff. So if blood is infectious, sending blood to the lab is something that you do with great caution. And in fact, part of our plan has been to devise on-the-ward testing that doesn't require additional samples to go to lab staff and potentially put extra people at risk. So it's a very different plan to the way we typically manage patients. Similarly, radiology is very different. If it can't be done on an isolation ward, it probably can't be done safely, and we have to deal with that as a very different standard of healthcare. So I'm going to pass over to Carol Epling now, who's going to talk a little bit more about employee health and student health, then with John.
Thank you, Cam. So at Employee Health and Student Health, we are actively involved with the Ebola response team and the emergency management team, and involved in implementing the very same protocols that have been implemented throughout the health system in our own clinics. We are also working with the volunteer employees who will be members of the Ebola response team on the isolation unit to support them and to evaluate them prior to undertaking those tasks to be as sure as we can that they're safe to participate in those activities, wearing that protective gear for the period of time that would be required. We know that we do not have any faculty, staff, or students traveling in the Ebola-affected countries of Sierra Leone, Guinea, or Liberia. We've been looking at this carefully now since early in the summertime. But we also know that as a global university, we have many travelers who come in to us, and therefore we are very mindful of screening people appropriately, and we are prepared to do the proper screening of anyone who is coming back from travel to any of these 3 countries. John?
As Kyle mentioned earlier, there are travel restrictions currently in place for undergraduates and health professional students at Duke to Liberia, Guinea, and Sierra Leone. That list of restricted countries may continue to evolve, so we are maintaining a restricted regions list online, and faculty, staff, and students can refer to that for any updates. Graduate students and faculty and staff are not under any specific restrictions, but there is an exception to the travel policy is required before any travel is scheduling any travel. For faculty, staff, or students who do travel to an Ebola-affected area, they are required to contact the university prior to return to campus. For faculty and staff, they would contact the Employee and Occupational Health and Wellness Office. Students would contact the Student Health Center for an evaluation. Depending on the results of that evaluation, outlined by Cam with basically the questions that were the second and third questions on that question tree, there may be a requirement for a self-imposed quarantine for 21 days prior to returning to campus. Again, as Cam pointed out, we're fairly certain that the 21 days is the incubation period, and if someone is asymptomatic for that long, the odds of them becoming ill are extremely low. Arrangements and support for students, faculty, or staff who do have to undergo such a quarantine will be made available and would be subject to prior approval from the university. Duke is maintaining an Ebola resources website. You can see the URL and address for it right here. That's continuously updated with latest news as this issue continues to evolve. It also contains all the important links to policies, procedures, and so we're encouraging folks to keep an eye on that website and refer to that for their initial questions or concerns.